Ever had a wrist fracture seem straightforward but then spiral out of control? I've been there too. Early in my career, I saw what seemed like a simple wrist fracture that turned into months of pain and frustration for both me and the patient. That experience was a real eye-opener, and that's why I'm here today to share the lessons I've learned. That patient took months to regain full function, and it really made me rethink how I approach wrist fractures. After 30 years in physio, I can confidently tell you there's no such thing as a routine fracture. In this video, I'm going to share the 3 key lessons that'll not only speed your patient's recovery, but also help you feel more confident and stress-free in your practice. These are the strategies and game changers that I wish I knew when I first started out. Before we dive in to the 3 key lessons, think about this. What's the most common mistake you've seen when rehabbing wrist fractures? Drop your thoughts in the comments below. We'll see if we're on the same page. We all know wrist fracture rehab usually involves controlling swelling, restoring range of motion, building strength. But let's be honest, how often do you see patients still struggle with nagging pain and stiffness? It can be incredibly frustrating for both them and us. Effective wrist fracture rehab requires more than just a textbook approach. I've seen it time and time again. That's why I'm sharing my top 3 strategies to outsmart complications and empower your patients to achieve lasting success. From aggressive, pain-free range of motion to attacking complex regional pain to early functional recovery, I've got you covered. And if you stay to the end, I've got a bonus tip that some physios might find controversial. Let's just say they actively dislike what I have to say. Let's conquer some complications. Section 1, push to recover functional motion of the hand, wrist, and forearm. Textbooks are for school. Forget about textbook perfect motion for a second. Let's focus on what really matters, patient function. Yes, we aim for full range of motion, but let's be real, most patients get by just fine with functional range of motion. I know my wrist and forearm motion isn't textbook perfect, but I feel fully functional. My motion doesn't limit me from doing anything. When it comes to the wrist, a functional range of motion is about 40 degrees of flexion and extension. Full fist, you definitely need that. Opposition into a tripod pinch grip is functional, and over 80 degrees of pronation supination is functional. Of course, we always try to get full motion with every patient, but I also work in the real world with real patients. In my experience, the 2 key functional motions to recover after a wrist fracture are the finger motion and the forearm motion. First, finger function, achieving a full fist with finger flexion and mastering a tripod pinch grip. Enabling the patient to curl their fingers into a fist and release is a basic hand function. For manual therapy technique, the therapist's thumb can gently push and apply pressure on the patient's fingers into flexion. Remember, no pain. Remember, heat can relax the tissues before manual therapy. And second, forearm rotation. Aim for over 80 degrees of both pronation and supination. Regaining significant forearm motion is vital for everyday tasks like turning a doorknob, pouring a drink, changing a light bulb. For a manual therapy technique, use a box grip on the distal radius and forearm. The therapist applies pain-free pressure to the end range of pronation and supination. Having the patient move during this motion is a manual technique like Mulligan's mobilization with movement. Those are to be considered. These motions, full grip, a tripod pinch grip, and the functional forearm pronation supination are essential for everyday hand function. Wrist motion, like I said, is functional after about 40 degrees of flexion and extension, and a dash of ulnar deviation helps. Instead of focusing solely on textbook range of motion, our goal is to help patients regain functional use of their wrist and hand. Encouraging patients to struggle to use that hand for daily tasks helps reintegrate that hand into the body schema and drives that awesome neuroplasticity. To achieve this, we need to empower patients with self-directed, consistent practice through pain-free home exercises. Patients are at home way more than they're in your clinic, and the real secret to your patient's success isn't some magical therapy technique, it's what they do on their own at home. Remember, no pain is the rule, but some soreness is normal. While pain-free manual therapy can be beneficial, active exercises promote long-term self-management and patient autonomy. You might be wondering, what about pain control? We've touched on that with heat and manual therapy and pain-free exercises. What about tendon gliding? Again, use it or lose it. Every patient is different. So if you see a stiff shoulder, don't forget to address that too. Do your assessment. Treat the patient that you see there. I'm just highlighting what worked for me. So let's shift from moving towards better motion to moving away from those neurosensory tissue complications. Section 2. actively prevent complex regional pain syndrome. Full-blown complex regional pain syndrome is rare. I've seen enough cases to know it's something you really, really want to avoid. And if you've ever seen one of these patients, let me know in the comments whether it was upper extremity or lower extremity and what you did to help them. I'd love to hear that. I know there are different names like Sudex atrophy and reflex sympathetic dystrophy, and there are different levels of affliction. So we need to be thinking about prevention with every patient. This addresses pain, this addresses swelling, this addresses sensation, and those mind-body issues. So here's what this means for your patient care. 1. Educate patients on how to differentiate between hurt and harm. Pain doesn't always mean damage. Think of it like a smoke alarm. Sometimes it goes off and there's no fire. Teaching your patients this can help stop fear from taking over. By understanding how pain works, patients can overcome fear and move with better confidence. This education empowers patients to take charge of their recovery, shifting from passive coping to active self-management. By educating patients on pain, we can get their frontal cortex on board with their recovery plan. 2. Closed kinetic chain exercises are a powerful tool in wrist fracture rehab. By engaging in multiple joints and mimicking real-life activities, these exercises help the body relearn its position sense and movement. This integrated approach promotes confident movement and overall hand use by combining sensory and motor and cognitive abilities. To introduce these exercises safely and comfortably, use a gradual approach, starting with small, manageable movements that build on a patient's confidence and function over time. This helps reduce the fear and improves overall outcomes. 3. Address swelling. Persistent swelling creates a pro-inflammatory environment that can contribute to chronic pain. Use cold or hot to get that extra fluid moving. Acute swelling usually responds better to cold application. Chronic swelling usually responds better to heat application. So see what works better for your patient. Use elevation to move that extra fluid as well. Elevation is a super useful, especially when combined with active motion like a muscle pump. So encourage your patients to do grip squeezes with their hand elevated on their head or on the back of the sofa, and teach self-applied retrograde massage to move that extra fluid. This also benefits from giving the patient self-sensory stimulation. Consistent home habits to address the swelling are the key to achieving the best results. Section 3, use it or lose it, promoting consistent hand use in wrist fracture rehab. The real goal of wrist fracture rehab is to help your patients reclaim their independence and get back to doing what they love, whether that's typing or picking up a hammer or chopping vegetables. To achieve this, we need to focus on functional recovery, which means helping patients use their hand and wrist and arm in meaningful ways. Instead of focusing solely on muscles and joints, let's think about what really matters to your patient. I remember one patient who complained about opening pickle jars. We never talked about pickle jars at school, so I had to think of a task-specific exercises, and I had to talk to my occupational friend about adaptive equipment. Ever had that panic when a patient asks something unexpected and you're thinking, okay, I got to get creative now? We've all been there. Now, let's consider some strategies for functional recovery. First, we want patients to practice everyday activities that matter to them. What do they have trouble doing? What can we tailor our therapy exercises to meet their unique needs? For example, if writing is a struggle, we might start by holding a pen, progress to practicing strokes, and eventually work on writing letters. Another strategy is to encourage patients to always use their affected hand in safe, controlled ways. This might start with simple tasks like gripping a plastic cup with water before progressing to breakable mug with hot coffee. Again, ask questions to see what they're struggling with. Consistent use of the affected hand isn't just important, it's crucial. It helps the brain relearn and adapt, ensuring lasting recovery. This is the use it or lose it. This is neuroplasticity. Whatever you call it, your patient needs those hands for all their activities of daily living, plus hobbies, plus sports, plus work demands. And yes, the patient did get back to opening pickle jars. How's that for patient-specific functional goals? It's also important to remember that recovery isn't just about the wrist and hand, it's about the whole body. We should encourage patients to stay active and maintain their strength in the uninjured limb and core. Consider giving your patients to go out for walks, add countertop push-ups, use waiter carries in their program. Get their entire body involved. Every patient is different, so we need to tailor our approach to what matters most to them. By celebrating those little wins along the way, we can really help patients stay motivated. And that's why we're here, eh? Bonus section, the power of active participation, empowering patients for functional recovery. Patients are more than just their injury, and physiotherapy is more than just moving the wrist around. It's about getting that patient back to life they want to live. Lasting change comes from what patients do, not what we do to them. I know a lot of patients love to sit with heat on their wrist and hand. Many physios love helping patients with their whiz-bang manual therapy techniques. In fact, relying too heavily on passive treatments can be detrimental, taken away from more effective and beneficial activities. While passive treatments may boost clinic revenue and cater to patients seeking comfort, the real key to recovery lies in active engagement. After injury, the brain's representation of the affected limb can shift, causing persistent pain. But with early, consistent movement, we can rewire the brain and promote recovery. This is where strategies like those closed kinetic chain exercises and pain-free functional use of the hand come in. Remember, we talked about those earlier. The challenge lies with patient expectation and ingrained beliefs. We need to help patients avoid getting stuck in the rut of passive treatments and instead move towards active participation. I told you this was controversial. We need to educate patients and help them understand that active participation is crucial for lasting change. This is like the mama bird pushing the baby bird out of the nest for its own good. Empowering patients is key to their recovery. By shifting from passive treatments to active participation, patients regain control and confidence. To make this happen, focus on active, pain-free movements that address their daily struggles, using functional exercises that mimic activities of daily living, and encourage patients to do these exercises as part of their home daily routine. Use passive treatments as an adjunct to active exercises. Get the patient's brain involved. Remember our discussion about hurt versus harm education and closed kinetic chain exercises? It's all about pushing for active, pain-free exercises at home. Recovery happens at home. That's where patients spend most of their time. If you know a fellow physio who says it's just a wrist fracture, send them this video. They'll thank you later. This is my 3-step plan to outsmart complications of a wrist fracture, restore pain-free motion, proactively manage complex regional pain, and empower patients with functional recovery, plus my shameless and controversial rant that active treatments are better than passive treatments. My goal here is to give you what I wish I had starting out. Instead of abstract physio mumbo jumbo, I want to give you practical, real advice that you can put into action. Now it's time to put these ideas into practice yourself and make a difference. Are you ready to take wrist fracture rehab to the next level? Let me know how in the comments how you plan to implement these strategies. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Another video for you to chew on right here, and by subscribing, you'll be part of a vibrant community that celebrates everything physio. Thank you.